They're not going to spend the time calling you and calling you. Oh, why should I spend my time calling you? Well, sometimes they just want to leave you a message. If you have no way of getting a hold of you except through a computer, you know, how does this
Let's go ahead and get you mic'd up because we're going to start here in just a few minutes.
And you'll put me back to where I'm supposed to be.
Okay. We've got a pocket. You can put that one in.
Yes.
Okay.
Will I be on now?
It's on. You don't have to touch that one.
Okay. All right. Does it have a clip?
Mm-hmm.
Okay. I just want to make sure. Do you want it? Does it matter if it's in or out on the clip?
Yeah, you can stick
Okay.
it in there. Be
Okay.
fine.
All right. I was giving a lecture, and I thought I had the microphone clipped on, and I did.
It fell off.
And I right in the middle of the lecture, it was clonk, and it hit the floor. So that was kind of funny.
Okay, this is your overhead mic.
Okay.
I'll go ahead and turn it on. If you start talking, it'll come in over.
Okay.
over
Where do
here.
I put that
You
one?
can pop. I'm gonna put it on the other side.
On the other side. Gee,
Go
I'll
ahead
just.
and turn that
I
on.
feel
So
like
it's
I'm.
on.
I feel like I'm wide up here.
You
I'll have my. I'll have my double-stranded microphones instead of
Yeah.
my. You know, you talk about double-stranded DNA.
There you go.
I'll have some double-stranded microphones. Now, is there a clock in here anywhere? If not, I can watch my watch. I
What
just
are you
didn't
looking
know.
for? Specific
Just
time?
yeah, I like to watch my timing on my slides.
Yeah, probably just on the edge of that computer. That might be.
Okay, let's see. Let's make sure. Like I said, I'll feel like I. Okay. Yeah, I see. Whenever. I just wanted to check the clock and see if I see a clock there. Oops.
Don't trip.
I really will feel like. I feel
About
like
1 minute, and we'll go ahead and
yeah,
introduce yourself.
1 or 2 minutes. Yeah, whatever works for you all. So, okay. And you want me to go about 45 minutes or so?
Yeah, because they're gonna ask for questions. and
Okay,
answers.
yeah,
And if someone does have a question, if you will repeat it so that everyone that's watching you through the
Okay.
computer will know what question was asked.
Okay.
You got your
Alright.
thing back off.
Okay, so how do I get back onto that?
Trying to stay off camera here.
There. Okay, I need to get back all the way back to slide 1, I guess. There we go. Okay, good deal. All right. So,
Go ahead and get started.
yeah.
You just have to just get their attention.
Yeah, I think probably a couple of people coming in. Okay, so are you ready? You ready?
Whatever you want.
Okay. Thank you very much for attending the meeting today. We'll go ahead and get started in the interest of everyone's time. Being a physician myself, I'm very sensitive to the time of physicians, nurses, pharmacists, and other healthcare professionals. So, and I want to make sure that we have the opportunity to discuss the topic today, as well as answer any questions. The persons in the back, is there any problem hearing me? I assume not, since I didn't see any sign. Okay, well, we'll go ahead and get started. We're going to talk about human papilloma virus vaccine today, and we're going to talk a little bit on some of the information related to how this vaccine came about, as well as the epidemiology of human papillomavirus, and also talk about some of the most current recommendations that are hot off the press related to this vaccine. I am Karen Landers. I am a pediatrician and public health officer with the Alabama Department of Public Health. I am the medical consultant for the immunization division as well as the TB control division. So if I start talking about multi-drug resistant TB in the middle of the talk, just wave at me and I will get back on topic. But again, we're going to talk today about a very important vaccine product. Now, I have no financial disclosures. If I did, I would not be standing here. But if anyone wants to make me an offer, you know, then who knows, I may decide to change jobs. I want to talk for a moment today about the HPV virus in and of itself, including the information related to how this virus is transmitted, what the current burden of disease is in the United States. Now, I'm going to talk a little bit about what is going on in Alabama specifically, but I do understand that there are other persons viewing this that are from other states, and I do have a couple of slides in my presentation related to vaccine coverage in other states as well as nationwide. And for those of you that might be interested in looking at further data, at the end of the presentation I have offered a couple of references, one from the CDC that further discusses vaccine coverage in the United States. I am also going to talk about the ACIP recommendations for HPV vaccine as they currently stand, recognizing that ACIP has just met, and I do think that there are going to be some additional recommendations coming out related to this vaccine. Now, I will attempt to not mention a product name, although there is only one current HPV in the United States. So if I do mention a product name, it is not an endorsement of any company or any product. It's merely that is the only vaccine available currently in the United States. But again, I will try to confine my remarks to stating non-valent HPV vaccine, which again is the only currently available HPV vaccine in the U.S. So let's talk a little bit about the HPV virus itself. Now, we know that the HPV virus is a double-stranded DNA virus, and the most important part of that virus is actually the L1 protein. And the L1 protein is actually the portion of the virus that is used to help develop the vaccine, and I will touch on that a bit later in the talk. In addition, we are aware that the HPV vaccine has oncogenic potential, and this is information that we have gathered through studies over the last 30 or so years, recognizing more and more with cervical cancer really being the cancer that was studied the most, that helped us to understand the role of the human papillomavirus in cervical disease as well as other cancers. The HPV virus infects the squamous epithelium, actually has activity at the basal portion of the squamous epithelium. I apologize to any pathologist. I'll try not to get too deep into that issue, but just to say that, again, it infects the epithelium, which, you know, when you think about the sites of cancer from HPV, it actually makes perfect sense. Again, this is where the infection occurs. So obviously we know that this would affect the sites that are that develop cancer. Now, when I'm talking about 40 types of HPV, I mean 40 types of HPV that we're really discussing in terms of the oncogenic or the non-oncogenic potential. There are actually about 120 types of HPV, some of which will cause common warts, common warts on the hands, on the knees, etc. But we're going to confine our discussion to some of the some of the viruses that are in the 40 types that I'm mentioning here. Now again, as I said earlier, there are oncogenic types, and we will talk about those briefly because the epidemiology of these viruses is very important to our vaccination of people with human papillomavirus vaccine. I will also mention the non-oncogenic types, and the reason being that this is also an important group of types because of the potential for the non-oncogenic types to cause health problems. And we have to also remember that, as I said earlier, we'll talk about HPV being a virus that can affect multiple tissues. Now, the oncogenic types that I will mention, of course, I really want to talk just a tiny bit here about the history of the HPV vaccine. We have 16 and 18 here, which if you look at HPV 16 and you look at the data on this, HPV 16 is probably responsible for at least half of all cervical cancers. And this is known because in pathological studies, the DNA from the HPV 16 is recovered from that tissue. Now, if you throw in HPV 18, you really account for, with these two oncogenic types, about 70% of cervical cancers. Then when you look at the other 5 types here, these really account for probably the remainder of the cancers that we are talking about. But again, 16 and 18 being the bulk of the disease that we see. And again, this is important in the development of the vaccine, because when the vaccine was first developed, of course, the 16 and 18 were 2 of the virus, particles that were used to develop that. And then, of course, the non-oncogenic types that I will mention, because there were other products out prior to most recently. Now, if we talk about the oncogenic types, as I mentioned, cervical cancer being the disease that we probably know the most about because of studying this for a number of years. But we have to also recall that human papillomavirus, as I mentioned earlier, infecting the epithelium, the squamous epithelium, obviously makes sense that we also could have anogenital cancers, such as anal cancer, such as penile cancer, such as vulvar cancers. Again, anogenital cancers being another important group of that can be infected by this virus. Now, oropharyngeal cancer, and I will speak to the epidemiology of this a bit later in the talk. Oropharyngeal cancer is a very important cancer that we have to be aware of now. We are actually seeing an increase in oropharyngeal cancer in the United States. So the opportunity to significantly reduce that disease by vaccination. And finally, low-grade cervical disease, which can be seen with the oncogenic HPV, as I mentioned earlier, as well as the non-oncogenic types. Now, if we look at the non-oncogenic types, we're really concerned about HPV 6 and 11, because 6 and 11 really account for most cases of genital warts that we see in the United States. And it's actually estimated that probably about 1% of the population has genital warts. And I work in the health department, so we do a lot of STD work. I know some of you are family physicians or pediatricians or OBGYNs and urologists, and all of you see patients that are infected with HPV virus, that are afflicted with this condition, which is somewhat of a challenge from time to time to treat these persons, and certainly a very annoying problem for them. Now, also the non-oncogenic types of HPV can be responsible for some changes in the cervical tissues, the cervical intraepithelial neoplasia. You can see that with the non-oncogenic types as well as the oncogenic types. And again, for those of you that do women's health are certainly aware that, you know, as we see women with abnormal pap smears, you know, these women may go on, it takes a number of years and go on to develop more severe problems and cervical cancer. But again, these are very significant. And the non-oncogenic types can cause those changes. Now, again, as I mentioned earlier, genital warts. Also want to mention something that is really important, and that's laryngeal papillomas, which we can see. And as I said earlier, low-grade cervical disease from the non-oncogenic types, as well as seeing low-grade cervical disease initially from the oncogenic types. Now, when we talk about the pathogenesis of HPV, I think something that's very, very important for all of us to know as physicians, nurses, pharmacists, and other healthcare providers that are educating and providing information regarding the human papillomavirus vaccine. Not everyone that gets HPV will develop either cervical cancer, anogenital cancer, oropharyngeal cancer, or even genital warts. I think it is important to inform people when we're talking about the vaccine that actually about 90% of people who get one of the HPV viruses or more than one HPV virus may actually clear that virus spontaneously. So we have to be aware that obviously while 1 in 4 people are infected with the HPV virus, they may clear that virus spontaneously. So that is important to be aware of. But for those people who do not clear it and have persistent infection, that's what we're talking about in terms of preventing HPV disease. And I don't think that, you know, while we talk about spontaneous clearing of the virus, I don't think we need to take comfort in that and say, well, you know, most of the time we're going to clear it, so we don't need to worry about it, because we have an opportunity here to reduce the risk of the morbidity and the mortality from this virus. Now, it's very important to be aware that when persons are infected with HPV viruses, you know, incubation may take a while, you know, a month to 2 years. It may take a while for them actually to manifest any signs or symptoms of this infection because, you know, it takes a long time again to incubate. However, and they may not show any signs or symptoms such as genital warts or CIN. They may just be persistently infected, and it may take many more years for them to actually manifest a cancer or a non-oncogenic form such as genital warts. Again, it can clear spontaneously, but when I'm speaking to patients about this, this is what I inform them, this is not a disease that, or multiple diseases that I am willing to just take that chance. I do think it's very important that we consider this as for what it is, and that is really primarily an anti-cancer campaign or an anti-cancer vaccine. Now, okay, so how is HPV transmitted? Well, humans are the only reservoir for the HPV viruses. And HPV is transmitted by sexual behavior. And we do know from studies that, for example, women, college students that are studied, that after about 2 years of sexual activity, that up to 40% of these women may be infected with HPV. So again, we've already got a significant group of people infected, and we have to be aware that not all of them are going to clear this virus. It is certainly important as we educate. I think not only are we talking about providing vaccine, but we're talking about educating people that early onset sexual activity is certainly an important factor in developing HPV infection. And also numbers of partners. The more partners that men or women have, the greater the risk of being infected. And that goes with any STD. Again, as I said, I'm sure many of you treat patients and are aware that, again, more sexual partners equals more STDs. Well, we talk about age. I talk about age primarily in terms of age of onset of sexual activity. Now, when we look at ethnicity, interestingly enough, we are actually seeing a higher rate of oropharyngeal cancer in white males in some of the data that has been seen more recently. So again, I don't think we can point to one ethnic group, nor would we want to single out an ethnic group, but rather say that some ethnicity can relate to transmission. However, again, we're treating everybody. We're not just talking about one specific group. We must target everyone with education and with the opportunity to be vaccinated. Now, I throw in smoking here not so much as a risk factor to get HPV disease, but knowing that smoking is also associated with oropharyngeal cancer. But if you look at the data independently, what you will see is that while smoking is associated with oropharyngeal cancer, as a separate risk factor, HPV is associated. So again, another reason for us to try to keep our patients from starting to smoke or educate them about stopping smoking. Now, I also mentioned here oral contraceptive use, immunosuppression, and pregnancy. And I'm putting oral contraceptive use in here because those of us who work in adolescent or women's health know that many times adolescents have the information that, well, I'm on an oral contraceptive, or, you know, in some instances they may have an implant, and okay, well, I don't have to use condoms because I've got a way to reduce my risk of pregnancy, so I don't have to use condoms. But the problem is that, as I always educate my patients, condoms do not, oral contraceptives or the implant do not stop you from getting an STD. So we have to be aware in our healthcare information to give patients that information. And again, immunosuppressed patients, you know, we're seeing a larger population of children growing into adolescence and into adulthood with diseases that were previously fatal, that now with certain medications that we can either treat those cancers or control those cancers, as well as the use of immunosuppressive agents, now the TNF agents. So we certainly do see, again, persons that have immunosuppressive conditions, but they're sexually active, and so they deserve information on HPV too. Now, if you think about 79, 80 million or so Americans, depending on what study you read, being infected with HPV, this is a significant concern, a significant problem as it relates to potential morbidity. And we know that HPV infection is most common in persons that are in the teenage years or early 20s. I have talked about the burden of disease, but if you think about some of the data shows between about probably 35 and 40,000 new HPV cancers per year in the United States. You know, that is a significant burden of disease, and that has actually increased in the last 15 or so years. Those of you that are interested, it is actually in the CDC paper that I am referencing, that we see this significant increase overall in HPV cancers. However, we are seeing that we have about a 1 to 1.5% reduction in cervical cancers, but we are seeing about a 2% increase in oropharyngeal cancer. So again, to be aware that currently HPV is the most common STD in the United States, and again, we're seeing an increase in oropharyngeal cancer, as well as the other cancers that I mentioned here on this slide. Now, just to talk about cervical cancer, as I said earlier, obviously it's about 90+% of cervical cancers are associated with persistent HPV infection. And a quarter of those occur in women that are, really in a fairly young age group. So I think this is, it is very, very important for us to be targeting, looking at this age group. Now, I do have people ask me, and I mentioned earlier, well, I'm on the pill, I've got the implant, I don't have to worry about HPV. I don't have to worry about sexually transmitted diseases. And, again, if persons are in monogamous relationships with a non-infected partner, that's certainly going to reduce their risk of developing HPV. However, we know that that may not always be the case, and in those particular instances, we should remind these women that this risk of this infection is still out there. Now, this is a fairly busy slide, but I throw this in just to show you the complications related if we're talking about cervical cancer, and again, as a message to reduce the risk of these complications. I mean, obviously, if these women have to undergo hysterectomy, or if they undergo the cervical conization or other procedures to, take care of their cervical disease, then that may affect their obstetric outcome. In addition, if we look at that as a risk factor for perinatal outcome, infant mortality, preterm labor, and preterm delivery, these are certainly factors that we would like to intervene to reduce. Now, as I talk about cervical cancer, again being something that we know the most about related to HPV, if you look at the rates, and again, I'm glad that there are people in the audience from other states, and you'll be able to look at this slide, which is available from the CDC, and I do have permission to use the slide. I think that we see overall the rate in Alabama is actually, fairly high. And when we look at our surrounding states, they're not a whole lot better than we are. So if you look at the dark blue, these are opportunities for us to reduce cancer and cervical cancer in these women. And also, those of us in healthcare now, I've been a physician for 41 years, and I think we have to look at more now than ever the economics of healthcare, although as I remind my daughter, who's also a physician, we really did do evidence-based medicine and look at cost back in my day. I think a lot of times younger doctors think that's a new concept. It's not. We've lived with that our entire careers. But if we look at the cost in billions of dollars in the United States, just in 2010, I think you can see that there is a significant amount of money to be saved by trying to reduce HPV disease. So again, I put this out here to show that not only through screening, and we're going to continue to do pap smears. Taking HPV vaccine does not negate the need for a pap smear, but if we look at it from the standpoint of routine screening and then having to follow up, and all of us know that when you have women with abnormal pap smears and you have to do follow-up, that becomes a very expensive process just from the practical standpoint of having staff, personnel, bringing people back in for appointments, procedures, etc. And again, other costs here, as I mentioned earlier, genital warts. So it's incumbent upon us to look at a way, as we look at ways to provide quality care to patients while reducing the cost of unnecessary burden of disease. Now, adolescents are an important group, and we're really targeting adolescents primarily when we're talking about HPV vaccine, but I want to give you some new information at the end of this talk. If we look at about half of adolescents have already engaged in sexual activity, sexual intercourse. If you look at about like 9th graders and then high school seniors, that is pretty significant, and again, an opportunity for us to intervene in this population while we still have this population under a level of parental or guardian supervision. And one thing I remind people when we're talking about vaccinating children, I tell parents, again, I'm a pediatrician and a public health officer, I tell parents, try to get your kid and get the vaccine and everything taken care of before they're out driving a car. You know, once they get that car, they're gone. So this is just something that all of us can relate to. Let's, you know, get them vaccinated while we still have that opportunity and before they have the risk of being sexually active and being exposed to the HPV virus. So in talking about the vaccine, I mentioned earlier how you're really looking at the vaccine from the standpoint of an inactivated virus particle, or if you will, a virus-like particle, a VLP, which is the antigen in the HPV vaccine. The only HPV vaccine as of the end of 2016 that is available is the non-valent. Again, the 9 types that I showed you earlier, the oncogenic and then the non-oncogenic. So these are the only viruses represented in the currently available HPV vaccine. And as I said earlier, we're targeting the 2 oncogenic types that are probably responsible for almost 3/4 of the cervical cancers, as well as the non-oncogenic for the anogenital warts and the other 5 types. Now, in talking about the vaccine, again, some of you may be familiar and may recall when we vaccinated, we started using HPV vaccine about 12 years ago in women and young girls, and then we introduced HPV vaccine use in boys in about 2011, and then the new product with the non-HPV came out in 2014. I, as a pediatrician and also an immunization consultant, believe that some of this confusion related to the use of the vaccine and the changing recommendations probably caused our rates of vaccine to not be as high, because you come in one year, you're told one thing, parents come back the next year, they're told something else, and then of course people get on the internet and they find all kinds of information that is not true about the vaccine, and as a result of that, you know, people just become very confused. They throw up their hands and they say, you know, I'm just not going to do this right now, I'll just do it later, I'll just do it later. And we know we put this off. The more we put this off in the adolescent age group, the more risk we're going to have that our adolescents are going to be exposed to HPV. Now, the current recommendations, what I did is I just tried to throw all the other recommendations out the window and get them out of my mind. The current recommendations, which I think really are being very helpful now, is that you can start the vaccine between 9 and 14 years of age. The immunologic studies have shown that they're, after completing 4 weeks after completing the vaccine, you have a very high antibody titer. Now the question is, what antibody titer is protective? Well, we don't know. I mean, I'll be honest with you, we don't know what titer is protective, but at least at this point in time we can say that, you know, there is an immune response to this. But another point that I've tried to make with parents is, let's get this vaccine while it's only 2 doses. And if we look at the data in terms of cost of giving 2 doses versus 3, and looking at the immunity, the results were non-inferior, and as a result of that, if you can vaccinate children prior to the 15th birthday with 2 doses of HPV vaccine, that's what you should do. Because if you get up to 15 years and older, you need to use 3 HPV vaccines instead of 2. And in addition to that, you have to, again, have the longer schedule. And we all know that we might get that first dose in, but it's harder to get that second dose and even harder to get the third. One thing I will mention here, however, is that you do not have to restart. And I have had people get their HPV vaccine over 3 years. You know, they come in once a year, get their HPV vaccine when they get their checkup. No, it's not been considered to be really a problem, but it is something that, you know, we do. So I tell people, well, I don't want to start over, but I'd rather give it on schedule because that's how it's recommended. So again, the current recommendations are to target females up to 26 years of age and males up to 21. However, Language is going to be coming out very soon because the FDA has approved the use of HPV vaccine up to 45 years of age. So language will be coming out from ACIP. I'm not sure when, but at one of their next meetings, I believe they meet 3 times a year, where there will be guidance for the use of the HPV vaccine in an older population. And the reason for that being is going back to looking at the opportunity to reduce the risk of these cancers and also these non-oncogenic changes such as genital warts. So again, expect from the Advisory Committee on Immunization Practices with the CDC that we will see language to use this vaccine. It has already been approved by the FDA in the older age groups. And I really think this is where we're going to have some impact on disease by doing this. Now, people have asked me about interchangeability of products. Well, practically speaking, since the end of 2016, there's nothing but non-valent available in the United States. But if persons only took one HPV vaccine and now they're entering, that was a few years ago, and now they're entering back into your practice, let's say they got an HPV at 13 and now they're 17 and they come back in, then you actually could go ahead and give them 2 more HPV vaccines and they would have completed a series. So you don't have to start over. But another question that has come up to me is, well, what about women we vaccinated with the 2-valent? And what about women we vaccinated with the 4-valent? And now we got a 9-valent. So what do? Currently, ACIP has not recommended repeating any of the HPV vaccine. Basically, if you got a full series, that's considered to be adequate because, again, we are looking at 16 and 18 and 6 and 11. And, of course, 16 and 18 were covered, and then 6 and 11, along with 16 and 18, were covered in the 4-valent. So, we're not currently recommending repeating HPV if people completed a full series of vaccine. And for those of you that are interested, that is actually on the ACIP webpage. There's a tremendous amount of information there. Well, after the vaccine, I think HPV has gotten kind of a bad rap for side effects. In my experience, I've probably given a whole lot of HPV in my career ever since it came out in 2006. And for the most part, what I've had, again, personally as a physician, but also looking at the data, is, redness, swelling at the site of infection. That's what I have tended to see, and that's borne out by the literature. Again, a couple of weeks after vaccination, you may see a very low-grade fever. Now, there was a lot of concern a few years ago about syncope post-vaccine, primarily in adolescents. And those of you that, again, have practiced family medicine or pediatrics for a number of years, I really always made my patients sit down and stay there, these adolescents, for, about 15 or 20 minutes and just try to make sure that everything was okay before they left, because generally they wanted to get this shot and run out and, go to basketball practice, and they hadn't eaten anything that day, they hadn't drank anything that day, or, they were living on the Red Bull energy drinks, and that's not an endorsement of that either, but just to say that, these kids are in a hurry sometimes. So really keeping recipients of vaccine there for about 15 minutes after these vaccines has markedly reduced the concerns over syncope. You may still have syncope, but they're not falling, hitting their heads or something like that. So again, the most common side effects were mild, and this is from VAERS data, VAERS data. Certainly, if you look at that data, there's just not information out there that this vaccine represents more side effects than were considered in the pre-trial. And again, millions of doses have been given in the last 12 or so years without significant side effects. I did look at some data on this in preparation for this talk, and found actually some very, very useful follow-up that showed that some of the adolescents that had been thought to have an extremely severe outcome from HPV actually had another disease totally unrelated to HPV that was the cause of their health problems. So I think it's important, if you want to explore that data further, there's a lot of good literature out there. Now again, contraindications to vaccine, this is what I tell people Anyway, if anyone that's had an immediate hypersensitivity to a vaccine component, this is exceedingly rare. And if you look at literature on this, again, the Pink Book, which is a publication of the CDC and the ACIP, has a section that basically provides a standing order for anaphylaxis, follow-up, or treatment, and then following the patient, certainly for making sure that they tolerate the treatment, and then further follow-up in emergency room, et cetera. But very, very, very rare with vaccines overall. And then, anyone with an immediate hypersensitivity to yeast. Now, I'm going to say I certainly don't have the world's experience. I have been doing this for a long time. I'll probably see it tomorrow, but I've never had anybody have a history of immediate sensitivity to yeast as far as patients, and I have seen a lot of patients in my career. Now, the pregnancy contraindication really relates to, other vaccines with the exception of Tdap. People are just, or hepatitis A or hepatitis B, if indicated. Again, we don't have opportunity to go into those vaccines today, but it's just because we don't have any data in pregnancy. And what we have told people is if you've started the vaccine and you discover that you're pregnant, just finish the vaccine after the pregnancy is completed. Now, in the last few minutes that I have, so I have the opportunity to talk about or answer any questions that you might have, I want to mention that if you look at Alabama, our overall completion rate in Alabama of 3 HPV vaccines is less than 50% in females and less than 23% in males. Now, we do have some data that indicates now, as of the end of 2018, it looks like we're going to be closer to probably 55–60% of females have had, one HPV vaccine, and about 50% have had 2. So, we're getting there. And in males, we're probably looking at about 40% of 1 vaccine and about 30% of 2. So I think we have a long way to go in terms of vaccinating our adolescents. But if we look nationwide, the vaccine data for 1 is about 60%, and for 2 is about 50%. So while we're not where the entire United States is, if you look at that data, you will see that we're not terribly bad compared to the rest of the United States, but we have room to grow. And again, I put this slide in, and as I said, I do have permission to use this slide because it is from the CDC. If you look nationwide, you're actually going to see that you really have very few states that are over 65%, and most states are hovering in the 40 to 60% range. And again, this is available on the CDC's website. I think it's important, and again, I'm only here to talk about the use of the vaccine product as a preventive measure. I'm not promoting a company or anything of that nature, but I think we have to be very, very aware that this vaccine can and should be given at adolescent health visits or other opportunities, that when the kids are in the clinic, we need to immunize the children. We need to take opportunities when kids come in for other situations such as routine sports physicals, camp physicals, etc. And we also need to review the immunization record even at acute visits, and that can be facilitated through our electronic health records, including our state health department imprint system. I'm sure many of you are participants in that. I do encourage parents to keep accurate records, but I think the answer to our having accurate immunization records on children is really our electronic health records, in spite of some of the pitfalls of those technologies, as well as using our imprint system, which is our statewide system that especially VFC providers, but other providers, can enter their vaccine data, so we have a statewide database. So we know and we can look up vaccines for children, and also we can have the opportunity for you all to do that in your office. HPV certainly was sensationalized several times by the media. There are a lot of reasons that people don't finish the shots. As I've talked with parents, I think the initial resistance that I've had from many parents has been that, well, my 9-year-old is not sexually active. Well, I certainly hope that they're not sexually active, because again, first of all, that is against the law. Secondly, that is abusive to the children, and no, absolutely, that should not be done. I mean, you know, we all agree on that. But what my message to parents is that, well, adolescents or young adults, at some point in their life, they're going to be sexually active. So let's take the opportunity now, while they're still here with us, and they're not driving a car, they're not out, you know, running around with their friends. I mean, you know, fortunately my kids are grown now, but I remember those days. So let's think about it in terms of long-term cancer prevention, and something I can do for my child now while they're still under my wing or under the wing of our parents or guardians. Now, we do know that perhaps as physicians, none of us has been as strong as we need to be in terms of our recommendations for this vaccine, because I think until we looked at data more specifically, I don't think that everyone was as convinced. But as I've seen some of the data come out, and specifically seen the increase in oropharyngeal cancers and seen the concerns over that this is a real opportunity for us that we have now, that we can seize the moment and we can vaccinate these younger people in order to reduce the spread of this virus. Now, you know, how long does this vaccine last? Well, you know, we don't know. We think that the immunity lasts 10 plus years, but we're not absolutely certain, and I do think some changes will come out with this vaccine in the future. But looking at the morbidity and the mortality and seeing that there are opportunities here to intervene on the side of our patients, not only to reduce their having these illnesses, but also to potentially control some health care costs, I believe that it behooves us as healthcare providers to get that information out there and get these kids vaccinated, and also look to what's going to come out with vaccinating older persons that, you know, could be at risk for these diseases, thus overall improving the health of our patients. I think I have about 10 minutes left here. This is my reference information here. There's a lot of information available. Also, you can go to our ADPH website if you're interested. But I'd be happy to answer any questions at this time. And for those of you, if you do ask a question, I will repeat the question because I understand that we are being videotaped. So again, if anyone has any questions at this point, I'll be happy to answer those. I know we're up against the clock, so if there are no questions, other persons can certainly feel free to leave, but I'll just open the floor for questions. Yes, sir.
Where is the vaccine produced? Is it in the yolk sac of an egg, or is it some other vaccine? You talked about allergies to the vaccine. It would be related to what factors are in the vaccine and where it was produced. And the other thing is, you mentioned what's available in the United States. What vaccine is available that's different outside the United States?
Okay. The first question was related to how the vaccine is produced, and the second question was related to what vaccines, HPV vaccines, are available outside the United States. The HPV vaccine is produced from recombinant DNA technology or recombinant technology using the L1 capsid protein, which basically allows the development of what's called a virus-like particle. So we don't have the concern about eggs or anything of that nature because it is the recombinant technology producing that. Previously, there had been concerns about one of the products, that there was latex in the stopper of one of the products, actually not the product that we're currently using. So again, because that's recombinant technology, we don't have the concern about egg allergy. The second question that you had about what products are available outside the United States, again, we're only using non-valent now in the United States. However, the other products, the 2-valent and the 4-valent products, are still available and used in other parts of the world. And the decision for non-valent was primarily related to the opportunity. We really had about 70% of the, for example, the 16 and the 19, we had 70% of our cancers covered there. Then the opportunity to look at the other 5 HPV that could really help us, and along with 6 and 11, but look at the opportunity to really cover as many of the HPV viruses that were potentially oncogenic. So again, the other products that are available outside the United States, the 2 and the 4 are still available, as well as other countries have the 9-valent too. So.
One other thing, you mentioned the problem of yeast.
Mm-hmm.
Where does that fit into the picture?
Well, because it's a recombinant technology, and any of the, and again, I apologize, I am not an immunologist, but any of the recombinant technology with vaccines, there are some of those that are potential concerns about immediate hypersensitivity to yeast, or basically an anaphylactic reaction related to yeast, because again of the recombinant technology used. So, did that answer your question? Okay, thank you. Those are great questions, and gee, I'm glad I brushed up on my biochemistry for that one. So, any other questions? Yes, sir.
Can pharmacists give this injection?
As far as in Alabama, and I don't know about other states, but in Alabama, pharmacists are able to give vaccines in persons, I believe it's 18 years of age and older. I may be wrong on the age, but it's close to the adolescent age group, that pharmacists, if it is in their pharmacy, again, based upon their reimbursement or their rules of their pharmacy, they can administer this vaccine. And that actually is probably one way that we're going to increase the utilization of the vaccine, is having more providers in the community. But pharmacists can, based upon the age group that they can vaccinate in Alabama, and I believe it's 18, but I may be wrong on that. It may be 15 or 16. Again, I'm not a pharmacist, but I do know that pharmacists in Alabama are allowed to vaccinate. So, yes, sir.
The recommendations you've told us, they're targeted to people that would be exposed to HPV by sexual contact. What about people that are exposed to it occupationally, like surgeons, OR scrub techs, and people like that? Because calorie smoke has been shown to have live HPV virus in it.
Mm-hmm.
But yet, we don't meet the criteria, the indication to get it under the indications you listed. So are there any indications for people that are exposed to it occupationally?
Okay. At this point in time, and actually that was addressed in some of the literature, at this point in time, when we're looking at HPV from a non-sexual or non-sexual type behavior transmission, there are not specific recommendations. You know, certainly one would hope and one would consider that persons that are coming into the medical profession, I mean, again, if we vaccinate people in the adolescent or the young adult age group, regardless of what profession they might go into, but that we would cover that population. But there is not an occupational recommendation, and that is actually stated in the literature at this point in time. There is not occupational recommendation for that. Vaccine is going to be increased, again, in terms of age groups, up to 45. As I mentioned, the FDA has approved that, I believe, about a month ago. But I do not have any information, and specifically ACIP has said they don't have a recommendation for non-sexual transmission at this point in time. Okay. Other questions that I can answer? Well, thank you so much for this opportunity. It's always very exciting to come and speak to a group of healthcare providers, and if anyone else has additional questions, I'll be here at the podium. Otherwise, I appreciate your time.